Welcome to this presentation on the neck, Part 2. During this presentation, we're going to cover 3 subject areas. We're going to begin by looking at the thyroid gland. Secondly, we'll visit the stellate ganglion. And then lastly, we'll visit the thoracic outlet. And as we move through each of these 3 topical areas, we'll discuss clinical correlations. So here we begin with the thyroid. And what I want you to understand here at the beginning is some really basic anatomy. First, the thyroid is made up of lobes. Here we see the right lobe. Next, we have the left lobe. And lastly, both lobes are connected by an isthmus. This particular slide shows a very important clinical relationship or anatomic relationship, and this is the relationship of the thyroid gland to the recurrent laryngeal nerves. Each laryngeal nerve, here is the right recurrent laryngeal nerve. It's lying within the tracheo-esophageal groove, and we see that groove between the trachea and the esophagus, which lies posteriorly. We also see the same relationship, however, it's unlabeled on the opposite side. So here's your left recurrent laryngeal nerve, and again, it travels in the tracheo-esophageal groove on that particular slide. Clinically, these are important during a thyroidectomy. The surgeon has to carefully identify these nerves and preserve them so they are not injured during the removal of the thyroid gland. We'll also demonstrate another clinical correlation of the recurrence when we talk about thyroid goiter. Here are some important aspects about the recurrent laryngeal nerves. Both recurrent laryngeal nerves are branches of the vagus nerve, and they will supply all the intrinsic laryngeal muscles with the exception of the cricothyroid. They are called recurrent as they come off the vagus nerve and then travel back upwards to either side of the trachea and ultimately to their destination of the larynx. The left and right recurrent laryngeal nerves do have some anatomic relationship differences. The left recurrent laryngeal nerve loops around the aortic arch in the vicinity of the ligamentum arteriosum, whereas the right recurrent laryngeal nerve loops more superiorly on the right side and loops under the right subclavian artery. Here is an important clinical correlation. Here we're looking at goiter, and this particular individual has a very enlarged thyroid gland, very large mass that's very visible. In this particular individual, there are multiple enlarged nodules. So this particular form of goiter is multinodular. Some of the symptoms that are associated with a goiter are as follows. One is coughing, and this has a mass effect on the respiratory passageways and the larynx. A second symptom is hoarseness. Very large goiters can involve the recurrent laryngeal nerves, and if they become involved, then they're unable to effectively activate the muscles of the larynx and can then create the hoarseness. Another symptom that can be associated with goiter is a difficulty swallowing, dysphagia, and this would be due to a mass effect. So the mass is compressing the structures that convey the bolus of food. And then lastly, again, due to a mass effect, you can have compression of your respiratory passageways in the area of the trachea, and making that a problem for some patients. A very common procedure to demonstrate whether or not nodules are functional nodules or non-functional nodules is to utilize a technetium 99M pertectinate scan. And we see here in the image the results of such a scan. Hot nodules are going to show up in this kind of coloration that we see here. This is due to the presence of functional thyroid nodules, and they're taking up the technetium 99. So these areas light up when you have a hot nodule region. A cold nodule is not a functional nodule, so these types of nodules will not pick up the technetium. And this area here represents a cold nodule in this scan. So here we are demonstrating more specifically some of the aspects of a cold nodule. And again, it's this area here, non-functional. These are usually benign. And then lastly, the odds of being malignant are going to be greater than the hot nodules. Here we're looking at the thyroid gland with respect to a clinical procedure, its removal, a thyroidectomy. Some of the indications for a thyroidectomy are what we just went through, for example, a goiter. Cancer of the thyroid gland would also be another indication for its removal. And then lastly, persistent hyperthyroidism. Some complications associated with a thyroidectomy include bleeding from the vasculature, either arterial bleeding or venous bleeding. Infection is always a concern in any surgical procedure. As we discussed not too long ago, hoarseness of the voice can occur if there's surgical injury to one of the recurrent laryngeal nerves. So again, it's very important to isolate them and protect them during a thyroidectomy. The last complication to highlight for your information is that some patients can have hypoparathyroidism. This is due to not being able to adequately identify the parathyroid glands before the removal of the thyroid. And as a result, the parathyroids are also removed, and then you do not have enough functional parathyroid tissue remaining for them to carry out their function.